Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss glycosylated hemoglobin as well as fructosamine. If we were to take blood from an adult and break open the red blood cells, we would get adult hemoglobin or HbA that will make up about 97% of all the hemoglobin present in the red blood cell. Recall from a previous video on hemoglobin that hemoglobin contains 2 alpha chains and 2 beta chains. There is also a small amount, less than 3%, of another hemoglobin called HbA2, which is made up of 2 alpha chains and 2 delta chains. In addition, even adults have trace amounts of fetal hemoglobin, the major form of hemoglobin when we were a fetus. Now we can separate these different types of hemoglobins by many different techniques. One of the most powerful technique is what's called ion exchange high performance liquid chromatography, or ion exchange HPLC. The use of techniques such as ion exchange HPLC can further separate the adult hemoglobin into hemoglobin A0, which is the major peak that you see here in the HPLC scan. That makes up about 93 to 95%. And then we have 5 to 7% of the HbA is what we call glycated hemoglobin, or HbA1. Now the HbA1 can further be separated by ion exchange HPLC into HbA1a, and you can see that peak here, HbA1b, and you can see the peak in your HPLC scan. And the major form is HbA1c that makes about 4 to 6%, and that's the peak here. So what is this glycated hemoglobin? Now glycated means carbohydrate, attachment of carbohydrate. So if you look at HbA1c, this is the hemoglobin to which is attached glucose. So this reaction that forms glycated hemoglobin, for example A1c, is a reaction between the aldehyde group of glucose and the amine group, some amine group on the hemoglobin. So in case of A1c, the amine group is the one present on the N-terminal valine of the beta chain. So this N-terminal valine of the beta chain, of this beta chain of hemoglobin, reacts with the aldehyde, forms a shift base, C double bond N, and then rearranges to form a more stable, what we call amidary product. So here you see the glucose is attached to the hemoglobin, and that's what hemoglobin A1c is. So this A1c peak is hemoglobin attached to glucose. Now A1b is hemoglobin attached to pyruvate. Remember from metabolism that pyruvate is a very important intermediate that is formed, for example, after glycolysis, where the glucose is converted to pyruvate. This pyruvate can also react with the hemoglobin present in red blood cells and form A1b. Now A1a, this peak here, is composed of 2 fractions. One is hemoglobin that is attached to fructose 1,6 bisphosphate, and which is, as you recall, is an intermediate of glycolysis, and the other is hemoglobin attached to glucose 6-phosphate, another intermediate of glycolysis. Remember, there's a lot of glycolysis going on in red blood cells. So a red blood cell has a lot of glycolysis because red blood cells get their energy through glycolysis. Okay, they don't have mitochondria, so they get all their energy from glycolysis, which means there's a lot of these intermediates present. Fructose 1,6 bisphosphate, glucose 6-phosphate, pyruvate, and of course glucose. And all of these carbohydrates can react with the hemoglobin to give you glycated hemoglobins. So this is what the A1c test measures, this band here. And one of the best ways to measure this is by using ion exchange HPLC. To understand this test, we need to look at the origin, distribution, metabolism, as well as excretion of A1c, what we did with glucose in the last video. So hemoglobin A1c has two parts. The glucose part of A1c we discussed in the last video. The origin is either from the diet or from within the body. The hemoglobin part of A1c is synthesized by red blood cell precursors such as the pro-erythroblasts as well as the erythroblasts. So these precursor cells synthesize hemoglobin, and they will differentiate into reticulocytes. The plasma membrane of the reticulocytes are almost matured red blood cells. So these plasma membrane of this reticulocyte will fuse with the plasma membrane of the endothelial cells that are surrounding these sinusoids present in the bone marrow. And this fusion between the plasma membrane of the reticulocytes with the plasma membrane of the endothelial cells of the sinusoids forms a temporary aperture. After the reticulocyte enters the sinusoid cavity, the endothelial cell will repair itself and close the space. This process prevents immatured red or immatured white blood cells from entering the general circulation. We want these red or white blood cells to enter the general blood circulation only after they are matured, after they have differentiated into matured red blood cells or into matured white blood cells. Okay, so that's the origin of A1c. Now what about the distribution of A1c? How does hemoglobin A1c travel in your bloodstream? And that's similar to hemoglobin itself. Hemoglobin, or as well as A1c, they are all water soluble, and so they will simply dissolve in the water part of the red blood cell cytoplasm. Now let's see how hemoglobin A1c is metabolized. And to do this, we will follow the journey of a healthy red blood cell as well as a damaged or an old red blood cell. So we have a healthy red blood cell here and a damaged or an old red blood cell through this organ called the spleen. So let's see what happens to a healthy as well as a old or damaged red blood cell as it goes through the spleen. The red blood cell enters the spleen via the splenic artery. So here is the splenic artery, and you see the red blood cells entering the spleen through the splenic artery. From the splenic artery, the red blood cell will enter now the central arteriole, CA, central arteriole. So here we have the central arteriole. The central arteriole is surrounded by this region called the white pulp, and the white pulp is composed of periarteriolar lymphoid sheet, which is very rich in T lymphocytes. So this area here, you can see the little dots here are T lymphocytes, little blue dots, and there are these beta cell follicles that are rich in beta lymphocytes. So this white pulp area is very rich in T as well as beta lymphocytes. Then outside the white pulp, white pulp, we have this region called red pulp. So we have the white pulp inside and the red pulp outside. And between the red and white pulp, shown in this dotted brown line, is a region called the marginal zone. The marginal zone is very rich in macrophages and beta cells that can produce the very large IgM, immunoglobulin M antibodies, and they can produce these IgM antibodies without the help of any T cells. So as the blood flow approaches the marginal zone area, the blood flow slows down, and the slowing down of the blood flow in the marginal zone allows these immune cells to scan for pathogens in the bloodstream. Now, after going through the central arteriole, the red blood cells will enter these open-ended capillaries that are called penicilli. Now, it is believed that some of these penicilli, like the one shown here, is connected to the splenic vein through the venous sinusoids. So in this case, the red blood cells simply will go from the penicilli into the venous sinusoids and then into the splenic vein and eventually out of the spleen. This type of circulation is called closed circulation. However, more recent research suggests that all the splenic circulation is actually open circulation. In this open circulation, the red blood cells travel through the penicilli and will enter these channels here. These channels right here called the splenic cords. These channels that you see between the venous sinusoids, what we call splenic cords, these channels are made from reticular cells as well as fibers, and they are very rich in macrophages as well as other immune cells. So in the open circulation, in order for these red blood cells in these channels to enter the venous sinusoids right here, they have to squeeze through these slits. These are spaces between the endothelial cells of the venous sinusoids, and these spaces are very small, about 0.3 to 2 micrometer. Compare that to the diameter of a typical red blood cell, which is about 7 micrometer. So this is what the red blood cells have to do. So from the penicilli, they will enter this space. So they will enter this space, and now to get out of the spleen, they will have to squeeze through these membrane spaces, these interendothelial spaces or slits, and then enter the venous sinusoids and then eventually be able to get out of the spleen. Now, a red blood cell that is damaged or old will have a serious problem in trying to do this. There are several reasons for this. One is the fact that the old or damaged red blood cell has what we call neoantigens on the surface, And these new antigens are recognized by macrophages. So there are a lot of macrophages around here. Because of this surface new antigens present on these old or damaged red blood cells, these macrophages recognize them very quickly and basically eat them up through phagocytosis. These new antigens are believed to be formed by the aggregation of this protein on the plasma membrane. It's an integral membrane protein called BAN3 present in the red blood cell, and this protein present on the in the plasma membrane of the red blood cell, it aggregates with hemoglobin that has been oxidized hemoglobin. So over time, remember, red blood cells carry a lot of oxygen. So there's a lot of oxidative stress all the time in red blood cells, and unlike other cells that have nucleus and mitochondria and so on, these cells don't have these organelles, so they have only a limited span of life, which is 120 days. And once this hemoglobin gradually becomes more and more oxidized, we see this hemoglobin interacting with this BAN3, forming these new antigens on these old red blood cells. And these new antigens are recognized by the immune system as a foreign chemical, and antibodies are produced against them. So once you have antibodies attached to these red blood cells, now macrophages and other phagocytic cells have very good receptors that can recognize this part of the antibody and eat up the red blood cell by phagocytosis. Another problem with old or damaged red blood cells is that on the surface they have eat me signals that we talked about in a previous video on executioner caspases. So examples of these eat me signals is the presence of phosphatidylserine on the outer leaflet of the red blood cell membrane. So the outer leaflet has phosphatidylserine, and this is recognized by macrophages and other phagocytic cells, and they will basically eat up this damaged or old red blood cell. And another reason why these red blood cells that are damaged or that are old simply hang around here and wait for their destruction by macrophages is because they cannot enter these slits. They cannot enter these slits that are found in these venous sinusoids. And the reason they cannot pass these slits is because of decreased red blood cell deformability. They cannot change their shape from spherical, which is impossible to enter the slit, into this almost flat-like shape so that they can go through the slit. So to do this, they have to be very flexible. And unfortunately, these red blood cells that are old or damaged, they have very poor deformability. They are not flexible. They cannot change their shapes. And this reduced deformability may be due to abnormal shapes like what we see in sickle cell anemia, high intracellular viscosity due to the presence of abnormal hemoglobins. These hemoglobins are not as water soluble as normal hemoglobin, and when they're not very water soluble, they tend to form aggregates, and that increases the viscosity in the red blood cell, and that increased viscosity is going to reduce the deformability of the red blood cell. And then there could be problems with the elasticity of the membrane due to defects in the membrane. One example of this is oxidation of hemoglobin, again due to oxidative stress, form what is called Heinz bodies. And these Heinz bodies attach to the red blood cell membrane. So if this is your red blood cell, you have oxidized hemoglobin, and these oxidized hemoglobin attaches to the RBC membrane. and that decreases the deformability of the red blood cell. So in this case of Heinz bodies, the macrophages actually will come and eat up the Heinz bodies, and the red blood cell becomes a cell. Then you'll see little what we call bite marks. So these are bite cells, red blood cells with sort of abnormal membranes, and we can see that under a microscope. So the take-home message is that an abnormal red blood cell, a damaged or old red blood cell, basically will be phagocytosed in the splenic cords. They will not be able to go back into the general circulation. So while the damaged cell is phagocytosed by the macrophages in the splenic cords, the healthy cell, which is very deformable, has no problem. It will simply enter the splenic cord, go through this slit by deforming, and then enter the venous sinusoids. And from the venous sinusoids, the healthy red blood cell will enter the splenic vein and then get out of the spleen and enter the general circulation. So a healthy cell can enter the spleen and leave the spleen without problems. A damaged cell, on the other hand, can enter the spleen, but cannot leave the spleen. It gets destroyed. So the spleen is not only a very important immune organ with all these various immune cells, but it's also an incredible filter that gets rid of not only abnormal red blood cells or old red blood cells, but also other particles, including parasites and so on. So in a way, the spleen determines the shape and size of the red blood cell that is in circulation. Now, once the macrophage phagocytoses the red blood cell is broken and the hemoglobin is released. Now, the hemoglobin has the protein part, the globin part. The protein, it will be broken down into amino acids. So in the macrophage, the globin or the protein will be broken down into amino acids. Now the heme part, there's also heme in the hemoglobin, that will be converted by the enzyme heme oxygenase. The heme will be converted into biliverdin, and then there's another enzyme called biliverdin reductase that will convert the biliverdin into bilirubin. Okay, and bilirubin is another very important test routinely used in the hospitals. So we will talk about this bilirubin in future videos. Then there's the iron part of hemoglobin that is either stored as ferritin in the macrophage, or it is transported out of the macrophage where it binds apotransferrin to form transferrin. Okay, so transferrin is the protein that transports iron through the blood circulation. So this is what we get in the metabolism of hemoglobin. We will get amino acids, we will get transferrin, which carries the iron, and then we'll have bilirubin. So let's see how these various products of the hemoglobin are excreted. The amino acid part, let's talk about this first. Average molecular weight of an amino acid is 110, so it's very small compared to the 40 kilodaltons cutoff for the glomerular filtration membrane. So these amino acids are water soluble, so they easily get filtered into the tubules, and once they are in the tubules, the proximal convoluted tubule will reabsorb these amino acids back into the bloodstream, And this is done by the help of sodium-dependent amino acid co-transporters. So these transport proteins here called sodium-dependent amino acid co-transporters, which will transport the amino acid together with sodium from the tubule into the proximal convoluted cell. Most of the amino acids, almost 99%, will get reabsorbed. A small amount will get filtered into the urine, including maybe the glycosylated valine, the valine that's attached to the glucose. So most of these amino acids are reabsorbed, and once they are reabsorbed, they are transported out of the proximal cell by basolateral amino acid transport proteins. So there are several transport proteins here that are able to take out these amino acids and send them back into the bloodstream. Now, what about the iron part of HbA1c? Remember, the iron is bound to transferrin. So we have transferrin iron, TFE, in the bloodstream. The molecular weight of transferrin is about 80,000. The cutoff for the glomerular filtration membrane is about 40,000. So when we say 40,000, we don't mean exactly 40,000. So let's say the range is about 30 to 60,000 Daltons. So if the glomerular filtration membrane space is only so much, range of 30 to 60,000, transferrin is 80,000, so the maximum here is 60,000. So you would expect that transferrin should not go through the filtration membrane and enter the glomerular cavity. Well, there is some transferrin that does enter the tubules, and the reason is because of the shape of this transferrin. So it is a bilobed shape, so that means it can actually enter the space in a certain direction. So because of this elongated bilobe shape, it does enter the glomerular filtration membrane. So this transferrin bound to the iron will enter the tubule, but it gets reabsorbed by endocytosis, receptor-mediated endocytosis. So the proximal convoluted tubule epithelial cell, they have receptors such as megalin, cublin, and transferrin receptors 1. And these receptors will bind to the transferrin and bring the transferrin back into the from the tubule into the cell, proximal tubular cell, by receptor-mediated endocytosis. Now, in the PCT cell, the transferrin part, the protein part, is broken down into amino acids. The receptors are recycled, they go back to the plasma membrane of the epithelial cell, but the transferrin part is broken down into amino acids, and these amino acids can be used by this cell, or these amino acids can be exported back into the bloodstream, as we discussed earlier. The iron part can be either stored in the cell as ferritin, or it could be used by the proximal convoluted tubule cell, or it could be exported out into the bloodstream bound to new transferrin. So those are the various possibilities. Now the bilirubin that is derived from the heme part of HbA1c, we shall discuss this in a future video. Now, since the red blood cell, from the time it comes out of the bone marrow, goes into circulation and then eventually dies get trapped in the spleen and destroyed, phagocytosed by macrophages. The average lifespan of a red blood cell is 120 days. So when we measure the A1c levels, it basically tells us a long-term average blood glucose concentration in a person. So the A1c test, unlike the fasting blood glucose tells you the blood glucose at the time when you took the blood sample. So it's just a one point in time test. However, the A1c test tells us the average blood glucose in the person for 120 days, 4 months. So in this respect, the A1c test is better than the fasting blood glucose test. There is a formula that relates the A1c value with the mean blood glucose, the average blood glucose, shown here. So if a person had a A1c of 16, so if this was 16, if you use the formula, the mean blood glucose will come out to be 442 milligrams per deciliter. So a person with an A1c of 16 has an average blood glucose of 442 milligrams per deciliter for the past 120 days. If the A1c value is greater than 6.5 on 2 separate tests, that means that person most likely has diabetes. So the A1c test today is one of the best tests for diagnosis of diabetes. Okay, so that's A1c test. Let's talk a little bit about fructosamine that we first mentioned in video 2.74. So in this test, the glucose is reacting with any serum protein that has amines that are accessible to it. Now, the most important abundant serum protein is albumin. So in general, this test fructosamine, when we say fructosamine, we usually mean the amount of glucose bound to albumin. So the reaction is essentially the same. The only difference is instead of hemoglobin here, we have albumin. The glucose reacts with the amine of the albumin, forms a Schiff base, and then rearranges to form a amidoride product. And now we have glycated albumin. So where does the albumin come from? Well, most of your albumin is made by the liver. This protein is synthesized by the liver and then secreted in your bloodstream. So the albumin comes from, the origin of albumin is the liver. Now, albumin is very water soluble, so it is easily transported in the liver, the bloodstream, comes from the liver, goes into the bloodstream, dissolves in the bloodstream water, and is transported to various parts of the body. Now, how is albumin metabolized? In the capillaries of tissues, the albumin will go between the spaces, will travel between the spaces, and will enter the tissue, and then will be taken up by the tissue cells, either by endocytosis or pinocytosis. The albumin then enters the tissue cells, and there it is catabolized into amino acids. What about excretion of albumin? Now, the molecular weight of albumin is about 67 kilodaltons. So the cutoff is 40 when we say a range of 30 to 60. So 67 is not too far from 60. So there is a little bit of albumin, less than 0.1% of the albumin is filtered into the tubules. This albumin in the tubules is then reabsorbed by the proximal cells, again by receptor-mediated endocytosis using receptors such as megalin and cubalin. So almost all of this albumin, 100% of this albumin, is reabsorbed by these cells. And once it goes into the proximal converter cells, the albumin is broken down into amino acids, which can be used by the cell or can be sent out into the bloodstream. So a few words about this fructosamine test. Glycated albumin, whenever a protein is glycated, there's a strong possibility the function of the protein may be impaired. So glycated albumin is known to have impaired ligand binding, because albumin binds a lot of ligands, including fatty acids. And albumin also has antioxidant activities, so the glycation may even affect its antioxidant activities. Since the lifespan of albumin is 20 days, a fructosamine test gives you the mean blood glucose in the patient for the past 20 days. Now, the fructosamine test is a good alternative when the patients have abnormal hemoglobin or anemia that can interfere with the A1c test. The reference range for fructosamine is about 200-300 micromole per liter. It is not used for diagnosis of diabetes. It's mostly used for monitoring, for the management of diabetes. So this is a little bit about the A1c and the fructosamine test. The next video we shall discuss urea. So until the next video, thank you very much once again for watching and supporting this channel. Have a wonderful day, and we'll see you in the next video.